for a kind introduction. Uh, I am doing this for last 3 years, and I sandwich myself between two talks of Dr. Peter Davis. It's very difficult to talk when the speaker like Peter Davis is going to be present. So anyway, I did it myself when I prepared the agenda, so no complaints. This one is like a controversial topic, the use of inhaled nitric oxide in preterm infant. Yes or no? I will try to give you the evidences, I will try to give you the recommendations, and then you will decide yourself in your setting that you can use it or not, and what condition you can use. I have to say that I'm using some figures drawn or created by my friend Dr. Satyan from California, Davis, University of Davis in California, and he did a lot of work in this regard and pulmonary hypertension. So my objective today is to understand the mechanism of action of iNO and discuss the potential effect, review the trials of iNO in the preterm infants. Now, this is the prime trials initially which we had is 25 weekers, 750 grams, 6-hour-old, high frequency, and PIE with oxygenation in 22, 28 weeks, 1150 grams, 36-hour-old, SIMV with oxygen requirement of 35%, and 25 weeks, 780 grams, 10 days old on CPAP with oxygen requirement of 40%. Now, the primary outcomes, they want to know the survival without the bronchopulmonary dysplasia. But before I discuss these trials, I have to go through about the nitric oxide and how it works. So this is a new, molecule which is invented in 1992. Is a naturally occurring molecule. Our body also producing it. In 1992, it claimed is the molecule of the year. It regulates our vascular tone, is gas exogenously administered to the lung, is potent pulmonary vasodilator. We all know about that in cases of pulmonary hypertension, especially with the pulmonary hyperplasia, we are using it. And of course, after the invention of this thing, it reduced the need of ECMO for those patients. The mechanism is simple. Inside the body, the L-arginine is converted to L-citrulline plus nitric oxide. With the nitric oxide synthase, the enzyme, it goes into the smooth muscles, and it's trying to open the calcium channels and the putting the potassium outside through the potassium channels, and this all can relax the smooth muscles and ultimately the vasodilation and decrease the hypertension. In 2005, I will try to go all the studies in the chronological orders. In 2005, this is the animal model, in the room model of, and they want to find it out the effect of the iNO on the chronic lung disease. And what they found out, the control in the you can see here, the compliance is higher in iNO group as compared to the control group. Here, the expiratory resistance is higher in the control group as compared to the iNO group. Similarly, the control group has the less volume with a higher pressure as compared to the iNO group, which has more volume with a similar or a little bit less pressure. So it really helping in this model to help or to ease out the ventilation. So this is happening that the same article suggests that it can improve the lung growth, and if you can see on the right hand of your, on the left hand of your screen, that the lung weight is increased and is statistically significant as compared to the control. Also, the DNA content is increased, with the building material of our organs is significantly increased. No difference in the protein content, and also the cell proliferation is also increased. So it really, in animal model, it helping to improve the lung growth. The iNO use in premature in 37 US children hospital is starting in the very high, and then it is NICU volume patients per year, it is started decreasing. But still, there are a lot of units which are using it. So the iNO use in these 37 hospitals, the size of the probability to be treated with iNO is increasing. Okay, so the mortality percentage is going up and down. Okay, so it's not really correlated with the use of the iNO. Now, the rationale for use in the premature RDS has some component of pulmonary hypertension. It improves the VQ mismatch. Dr. Peter Davis talked about the VQ mismatch in the RDS. iNO has other effects on air resistance and surfactant function, and also it affects the lung development, as we saw in the balloon model. So this is the causes of hypoxemic respiratory failure in the neonates. How it is developed is the figure drawn by Dr. Satyan, and what he's saying that there's a lot of things going on which can lead to the hypoxemic respiratory failure. The bidirectional shunt, the bidirectional at the PFO, acute pulmonary vasoconstriction, genetic defects, intrapulmonary anastomotic vessels, impaired pulmonary venous drainage, and alveolar capillary dysplasia. So all this can help to develop this disease, which we call hypoxemic respiratory failure. And this all lead to the cyanosis in preterm babies. So other than the congenital heart disease, this is the flow diagram that what will happen, and it is very easy to understand that if you have a left ventricular dysfunction, low left cardiac output, left to right sent to the PFO, right to left sent to the PDA, the oxygenated blood return to the pulmonary circulation, which can give you the desaturation and the cyanosis ultimately. And similarly here, the low pulmonary blood flow, right ventricular dilatation, right to left sent, and PFO shunting, they decrease the PVR, decrease the right to left shunting, better PVF and oxygenation if we are on this side of the this flow diagram. So this is the one way to understand the physiology, what is going on in hypoxemic respiratory failure. The short-term and the long-term benefits. The short-term benefits, we all know pulmonary vasodilation, improve VQ mismatch, reduction in inflammation and neutrophil accumulation. But the long-term benefits are the reduction in oxygen stress, improved surfactant function, improved alveolarization, and reduced vascular remodeling and improved vascular growth. Having said that, but it is not that all these potential benefits we can apply in all type of the pathology. So, for example, if we have the hyperdynamic pulmonary hypertension or pulmonary vein stenosis, mitral stenosis, LV dysfunction, this is not going to be worked. The gray or the pink area, which is there are really chances that the iNO work in the preterm lung. For example, the abnormal transition, asphyxia, acidosis, hypercapnia, hypoxia, PPHM due to MAS or pneumonia. And the gray area, we don't know that if it really work or not. We will go through some evidence. There are potential toxicities of the iNO, like methemoglobinemia, platelet dysfunctions, and the generation of the nitrous oxide, unknown additional toxicities in preterm infant, which can lead to the damage their lungs and their cardiovascular system. The inhaled nitric oxide for respiratory failure. So this is my first thing to discuss, that what are the evidence? Is really it help in this pathology, or it help in decreasing the BPD? Let's see some evidence regarding that. So there are studies of iNO and preterm infant. There are multiple randomized controlled trials, but the major difference in timing when you should start the iNO, right from the delivery room or the later. What is the dose? Start from 20 ppm or the 5 ppm, or in between. How much is the duration, and what is the real population for that disease? So as I told you, these are the three major studies done in different time in 2005, 2006, and then again in 2006 to see the effect of iNO in preterm infants. So the earlier rescue with iNO is suggested by Myers and his colleagues, published in 2005 in New England Journal of Medicine. He really chose a very less than 34 weeks, and birth weight is 401 gram to 1500 gram. Oxygenation index to start this treatment is more than 10, eligible for 4 to 120 hours of age. And initial dose of 5 ppm every 4 to 8 hours. Responder defined increase by the PO2 by 20 mmHg in 30 minutes. So it's really, they want to start iNO as soon as possible and see the effect. So the major outcome, death or BPD, is not statistically significant. Death alone is not statistically significant. BPD alone is not statistically significant. Same with the grade 3 or 4 IVH and PVL and the severe ROP. The major outcome by the birth weight, if you can see less than 1000 gram and more than 1000 grams. Death or BPD, no difference. The difference in the less than 1000 gram, the death is higher and it is statistically significant in the iNO group. The BPD is not any difference, and the severe IVH is higher in the iNO group in the less than 1000 grams. And if you can see more than 1000 grams, the death of the BPD is statistically higher again in the placebo group, and the death is higher in the placebo group. BPD alone is higher in the placebo group, but not statistically significant, and similar to the severe IVF PVF. So there's a very mixed type of thing, but definitely less than 1000 grams have a side effect of the can be the effect of the or adverse effect of the iNO mortality. This is the 2020 study by Dr. Satyan and Chandrasekhar. It's just published September last year. Early hypoxic respiratory failure and extreme prematurity, mortality, and neurodevelopmental outcome. They have almost 8,000 infants in NICHD unit research network, less than 26 weeks, less than 1000 grams. The maximum inspired oxygen is more than 60 and less than 60. In a group more than 60, they labeled as early hypoxic respiratory failure, and they exposed to iNO. Its death by 18 to 26 months is 59%. Moderate to severe NDI or neurodevelopment among survivors is about 44%. Those are not exposed to iNO, the death is about 49%, and the neurodevelopment adverse outcome is about 41%. If it is less than 60, the death is about 20%, and the moderate to severe NDI among survivors is about 30% who are not exposed to the iNO. So really, it is a very different study, and it is showing us that iNO has this adverse effect in those babies. This is the same in the which I just mentioned about that this thing, but it is the early hypoxic respiratory failure alone, then plus iNO, and then plus iNO with the of this thing. So this is the same which we just talked about that. Then 2005 and 2020, then 2006, we have another study which is late iNO at risk infants. So these are the two early rescue iNO. Now this is the late iNO at the risk infant. They choose less than 32 weeks and mechanical ventilation or CPAP at 7 to 21 days. And initial dose is 20 ppm times 72 hours. The major outcome, again, the death of BPD is that is the placebo is 63.2%, and it is statistically significant. Discharge at 40 weeks post gestational age is also statistically significant in that in the iron group. But the death alone and the 44-week discharge is not significant. Survival without BPD is 7 to 14 days. In iron group is higher. 15 to 21 days is not that much higher. The racial division, the white, no difference, but in black Americans, kids are statistically significant in iron group. Other finding, what we find it out is less severe BPD with INO, no acute change in pulmonary mechanics, less use of bronchodilators at 12 months, cost effectiveness, no difference in developmental outcome, no evidence for other toxicities, and it improves effective function. So again, there's a very mixed results of what we are getting. So the questions are, trial selected out infants who survived first week, is INO is most effective in infant high risk to develop BPD when started earlier. So at what time we should start? Is there any racial difference in INO effects? Because one study I just showed you, there's a difference between the white race, Caucasian race, and the black American race. Does longer therapy at a higher dose provide additional benefits? These are the questions arise. The INO administration trial, which we just talked about, they have they are the 4 trials and they use different doses. The Ballard trial used 20 ppm and then 10 and then 5 and then stop. The Schreiber trial used 10 and the Kinsella trial used 5 and randomized also used 5. So there's a heterogeneity among these trials also. If then all these 4 and 5 trials and the other trials, then in 2011, there's a meta-analysis published in Corporate Review, in Pediatrics Journal by Askey and his colleague. And what they found it out that is there is no difference in outcome if you compare to the death or the chronic lung disease. Similarly, the primary outcome combined favor the INO and favor the control is no difference. As you can see, they are all crossing the line of confidence interval. The meta-analysis for the secondary outcome, which is death by 36 weeks, death by discharge, severe IVL, gross air leak, pulmonary hemorrhage, and the severe ROP also not different in this meta-analysis. Outcome by dosage and durations, and same meta-analysis, that of the CLD and duration of iron treatment is not that difference, and it is crosses the line of confidence interval. So there is no agreement on that. Then there is one trial which is called the neonatal trial. This is the pilot study. The peak population is the infant less than 1250 grams, less than 30 weeks. Intervention is randomization to INO and comparison with the INO with no placebo. Outcome increased survival without BPD and the time limit is to 36 weeks post-menstrual age. So INO dosing they begin with 20 ppm and for 70 to 96 hours and decrease to 10 ppm until day 10 plus minus 34 hours and then 5 ppm to complete 24 days of therapy. Therapy continued through 24 days even if the respiratory support no longer needed. So this is a long therapy for 24 days. So there must be a cost effectiveness for this therapy also. This is done by Dr. Yoder in 2014. So these are the iNO for the prevention of the PPD, and these are the randomization. Placebo is 222, iNO is 229, some loss follow is completed at 36 weeks is 204 in one group, placebo group at 280, almost similar in iNO group. The results are like this. Survival without BPD at 36 weeks post-menstrual age was similar between the placebo and inhaled nitric oxide group. So imagine how much cost you incur for 24 days of iNO, and the results are the same. There is no difference in incidence of common morbidities were observed. Respiratory outcomes on discharge at home at 1 year and at 8 to 24 months is also did not differ between the groups. So the conclusion at this point, Dr. Yoder made it that iNO is safe and well tolerated, no difference in primary outcome, did not improve survival without BPD or respiratory and neurodevelopment outcome at 18 to 24 month premenstrual age. After this study, there is a consensus report published in the American Academy of Pediatrics, use of inhaled nitric oxide in preterm infants, and they are against to use it, and they said that I'm reading the same what they wrote. The result of randomized controlled trial, traditional meta-analysis, and individualized patient data meta-analysis study indicate that neither rescue nor routine use of iNO improves survival in preterm infants with respiratory failure. And the evidence quality they give A, and the grade of recommendation is strong. The other statement they make, the preponderance of the evidence does not support treating preterm infants who have respiratory failure with iNO for the purpose of preventing or preventing the BPD, severe IVF, or other neonatal morbidities. And evidence quality is high, and the grade of recommendation is strong. In 2015, the off-label use of inhaled nitric oxide after release of NIH consensus statement, which I just did by the Reese Clark group, and what they conclude that the rate of off-label iNO use in the preterm infant continue to rise. So the people are still using it after those statements, despite evidence revealing no clear benefit in the population. This pattern of iNO prescription is not benign and comes with economic consequences that we just saw. And the off-label use, they are using it in the preterm infant, the prolonged rupture of membrane, PPHM, ductal right to left shunt, bidirectional emulsion, hypoxic respiratory failure, preterm infant to prevent the BPD, cardiac catheterization left. Sometimes they are using it and non-invasive. In September 2020, the UNO trial or European Union nitric oxide trial, they published their 7-year follow-up of those babies, and they found it out that for prevention of BPD in very premature infant with respiratory distress did not result in long-term benefit or adverse long-term sequelae. In the light of current evidence, routine use of iNO cannot be recommended. So this is the very latest in September 7, 2020. The similar reports published for the respiratory failure from 2016 in Cochrane database, which shows no difference between the control group and the iNO group when you look at the mortality, when you look at the ECMO. Yes, when you look at the ECMO in this meta-analysis, they favor the iNO group. So inhaled nitric oxide in extremely weak neonates with respiratory distress syndrome, which is the conclusion in 2018. After all that is off-label prescription, is not associated with reduced mortality BPD among extremely premature infants. These are very prospective trials. Because of the time, I'm going to now, the association of early inhaled nitric oxide with survival of preterm neonate with pulmonary hypoplasia. So this is the another study published in 2018 that if you have a hypoplasia plus PPHM, the exposed babies with iNO has a better result as compared to unexposed. But if you have a hypoplasia but no PPHN, then there is no difference between the exposed group and the unexposed group. This is the last study which is just published a couple of months, I think it's in July. When to say no to nitric oxide in neonates, and they mention some absolute contraindication, for example, vector-dependent lesion, and they very beautifully illustrated by Dr. Satyam and Steve Aiman in this group. The other, they want to absolute contraindication is a severe left ventricular dysfunction. So if you have the cardiac problem, it is better not to use the nitric oxide. So the practice point, they said the use of iNO in preterm high proximity respiratory failure due to pericardial disease without pulmonary hypertension is lack evidence, and they not recommended it. Recommend selective use of iNO with HRF due to PPHN. Maybe we can use it. Routine iNO used for prevent BPD is not recommended, and in neonates with the CDH associated with LV dysfunction and pulmonary hypertension, use of iNO can potentially lead to respiratory deterioration. So this is the last point, is very important to understand, because whenever we have hematodiaphragmatic hernia, maybe we are trying to rush to start nitric oxide, high frequency. It is not that recommended now. We have to do the echo first, see the LV function. The LV function is good, and there is a significant persistent pulmonary hypertension, then obviously then you can think about iNO, but do not jump at the CDH with, you have to start with the nitric oxide. So to end with, so what do we know right now? Is there any benefit of iNO use in extremely low birth weight? The answer is no. Benefit of early low dose iNO in the ELBW. Is iNO affect the lung development? Yes, in the animal model it can affect lung development. Is iNO increase the risk of brain injury? Yes, it can increase the risk of the brain injury, especially if we have the babies less than 1,000 grams. Is iNO recommended in documented pulmonary hypertension? So documented means if the person who is well trained in the echo do the echocardiogram and find it out as the pulmonary hypertension, then yes, it is recommended to use the early iNO, like I showed you, the hypoplasia plus the PPHN, it helps the babies. Should we encourage use of iNO and HRF? No, we shouldn't. We should discourage it. We should maintain it by giving surfactant, by the laser technique, and to try to continue with the CPAP. Most of the babies improve on that. It's not that just intubate the baby and try to give the gentle ventilation. Need for randomization trials of vasodilator in BPD patient to assess efficacy? Yes, there is need for those trials. That's all. We will take the discussion, and thank you very much. Back to you, Dr. Aiman.